So, you can hear me. Um, Very good morning to you all. And in Estonian, I think I would say tere hommikust.
Tere.
So delighted to be joining you for this conference this morning. And I'd like to congratulate the organizers on the choice of topic, which has never perhaps been so important than now, as Europe faces so much uncertainty and challenges, both in the public health sense and more broadly, socially and economically. So before I start, I'd like to take the opportunity to congratulate the government on the development and preparation of the Green Paper, which I think provides the essential framework for strengthened action and investment in mental health. And in fact, last year in March 2019, I was happy to participate in one of the mental health roundtables. So I was able to see for myself the very collaborative way in which the multi-sectoral, multi-stakeholder consultations around this area were taking place. And that in itself is a very strong sign of good planning and good governance in mental health, that there is broad stakeholder engagement and involvement right from the start. So at this point, let me share my screen. I hope you can see this fine. Let me just make it even larger. Great. So this is the presentation title. Before I get into this topic, I did notice the theme for the day, which was making the invisible visible. And I think, if I put it like this, that right now in so many countries, we're faced with an invisible threat, right? You can't see it, even though it is out there somewhere. The signs and symptoms often set in before you even know about it. And severe cases or the course of illness can even result in death. The impact on affected individuals and families can be very hard and long lasting or enduring. And finally, most countries are not well equipped to prevent or manage it well. So actually, I could be talking about COVID-19, of course, but actually I'm more talking about the threat that we cannot see posed by mental health problems, and psychosocial disability. So at a public health level, socioeconomic level, it's not just COVID-19 that is an invisible threat. I think we have some pre-existing threats as well that we need to consider. So if I start by talking about mental health in numbers, some examples of why this public health challenge, let's call it, is perhaps under-realized, underappreciated. I think we can sum it up in some statistics. These are examples, but the first one is that I think is that 100% of us, we need good mental health to really flourish and enjoy life to the full and be able to interact with our friends and family and colleagues and so on. So that's number one, and yet about 1 in 10 of us, and in fact even more, 1 in 5 of younger people will be experiencing a mental health challenge at any one time. So this is often hidden, invisible, it's suffered in silence, and often goes untreated. Based on prevalent statistics, we can compute that more than 100 million people in the WHO European region, which is all of the EU member states and 27 other countries, right through to Central Asia, have a mental health challenge or difficulty at some point in the year. And yet the coverage level, the treatment coverage for common mental health conditions like depression and anxiety is really very low. Even in higher resource countries, less than 30% of people get the care that they support that they need. And in less resource countries or contexts, it's as low as 1 in 20 or 5%. So we have a huge challenge there in terms of reaching or moving towards universal health coverage for people with mental health conditions or psychosocial disabilities. And as already alluded to, one of the most drastic outcome is, of course, suicide. And globally, there are approximately 800,000 deaths per year by suicide, which is equivalent to 1 every 40 seconds. The European region has one of the highest rates of suicide mortality, over 140,000 deaths per year. And it's a leading cause of death in certain, including very worrying, amongst adolescents and young adults. So these are sort of examples of what I'm referring to as this very significant public health threat, which is often somewhat invisible or overlooked as a priority. So what to do about this? So I've got 3 little points I'd like to try and cover in the next few moments. One is around some of the key principles and approaches, and you've already heard about some of those, which I'll reiterate briefly. You've also heard about COVID-19 and mental health, but I can't not talk about that in the current context, and can give you a WHO and UN angle on this. And then thirdly, the all-important question is, okay, we have significant challenge here, what to do about it, and what can we learn and take from other countries, other contexts, other experiences. So setting the scene, at a policy level, with WHO has its global and also a European mental health action plan. The global one has been extended out till 2030. The European mental health action plan is expiring at the end of this year, and we'll be looking to develop something for the region for next year in consultation with member states. We also have documents relating to, for example, suicide and dementia, early child development, and other topics. A lot of countries do have mental health and suicide prevention strategies, also mental health legislation, although this often takes much longer to bring to final passage in governments. And of course, we have increasing availability of good quality evidence, tools and resources to help mental health protection and also suicide prevention. In the Estonian context, I don't need to tell you, the situation is improving, particularly with the development of this broad cross-cutting green paper. Although we, as also pointed out in the first intervention, there are still concerning rates of suicide, particularly amongst males. The European Mental Health Action Plan, which, as I said, is expiring this year, has sought to not only, if I take the last of these 3 points first, is not just about access to effective and safe services that meets people's needs, but it's also got a very clear emphasis on a rights-based approach, so the rights of people with mental health problems or psychosocial disabilities that can offer them equitable opportunities to attain good quality of life and address the all-pervasive issue of stigma and associated discrimination. And then the first point is also very much in line with the discourse of this conference, which is that it's not just about the deep end, about the trying to improve with identified or identifiable mental health conditions, but it's also about improving the mental well-being of the population and reducing exposure to known risk for mental health. So if I think of it in this very simple diagrammatic way, you can think about mental health dimensional rather than a purely categorical sense. So the categorical definition of mental is you either have a mental disorder or you don't have a mental disorder. So it's a very binary kind of approach to thinking about it. But the reality is that we're all on a continuum. We're all on this line somewhere. We may be experiencing good mental health for many years or much of our life, but then maybe we have a life event that distresses us. And for some people, that may lead to a mental health condition or disability. So we need to think of it in this very sort of dimensional sense. That, of course, corresponds to some of the key dimensions of intervention and the targets for that. So it could be around mental health promotion, prevention, remission, or recovery. Some of the strategically vital approaches to mental health protection would include definitely a life course approach, a rights-based, person-centered approach, of course, a evidence-based approach, and also, very importantly, a multi-sectoral approach. So I'll just say a little bit about a couple of those at least. Starting with this one, which in a way summarizes some of the comments which or contributions which were already presented in this session. You see here this life course trajectory right from actually prenatal through to childhood, adolescence, adulthood, and into older age. And at each of those stages in life, we are exposed to some risk factors, which are shown in the red arrows pointing downwards. But for every risk factor or adverse potential factor, there are also protective factors. So the job of policy and practice and interventions shown in the blue arrows is to reduce exposure to the risk factors and promote the exposure to the protective factors. So they work in synergy, I think. So if we take childhood, for example, as a life course stage, we know that some of the risk factors would include obviously maltreatment or abuse of children, and having a bad relationship between children and parents or other family members, and disruptive behaviors. So these would be examples of the risk factors. And the protective factors would of course correspond to that, the other, flipping the other side of the coin, which is to ensure that children grow up in secure and supportive family or home environments, just as like when you move into school-age children, having a positive school environment is very important, and having exposure to bullying and things are very disruptive to mental health formation. So at each of these different points in the life stage, we have rather different risk factors. So you get into adulthood, it could be more issues around workplace or unemployment as a risk factor, or insecure or stressful working conditions. So for each of those, we need different policies and targeted intervention to address those different types of risk factor. But the overall, I think, important message is that because it's all interconnected, it's so important to get it right early in the life course. So, if children are exposed to adverse risk factors, they will carry those through perhaps into adolescence as more, let's say, chance of risky health behaviors. Could be substance abuse, for example, and those in turn can reduce their chances of high levels of scholastic achievement, and that might affect their chances of employment. And if you have low employment, you have less income, and you can see how one thing can trigger the next, and even go not just across the life course, but even across generations. So early intervention both in the life course and early in the course of any problems or illness that may arise, I think is a key message. Another point I wanted to raise here quickly is around the very important issue of equity and access. So recently there was a report looking at the inequalities in mental health using the WHO 5 Mental Wellbeing Index. And what it basically showed, and I've highlighted Estonia results for you. I hope you can see them okay. But basically, the lower you are in the socioeconomic in status, the more risk you have of having higher scores on or mental health. And so I think this is a very also necessary ingredient to appropriate policy and practice so that we are addressing the underlying determinants of mental health, which are partly, coalesced around people with less socioeconomic resources or status and associated maybe restrictions on access to opportunities for education, employment, and so on. So turning to the COVID situation, I'm just going to check my timing, running a bit low. So this is from the UN Secretary General, who put out a policy brief earlier in the summer looking at COVID-19, the need for action on mental health. And the key kind of impacts can be summarized in three main ways. The first, of course, is the direct effect of COVID outbreak on people's psychological state. So the fear and anxiety that goes with that. So an inherent reaction that we have as humans to a disease outbreak, a threat to our health, ourselves or our loved ones. But then, of course, the measures, the infection prevention and control measures brought in to control the spread of the contagion, of course, have their own independent effect on mental health, including the isolation, lockdown, quarantine measures that we've all been subjected to. And that, for a lot of people, is extremely stressful and difficult. And whilst your results nicely showed that people have been able to adapt, in the first few weeks and months, this caught a lot of the population out, by surprise, and consequently, you saw these very high levels of stress in multiple countries. I saw the NIHD survey in Estonia showing similar kind of responses to this range shown here. So what to do, and then the biggest of all could be, we still remain to see, but the indirect effects of the economic fallout in terms of unemployment, impoverishment, and exclusion, of course, is absolutely enormous, and remains to be seen just how extensive those will be. So what to do about this? Of course, adopting a whole of society approach. So it's not just seen as a health sector approach, for example, to respond to is one thing. So it's a very cross-cutting issue. Of course, enabling or ensuring the availability of mental health and psychosocial support and the supporting the recovery through a sort of building back better approach. These are some of the key recommendations from this report. The particular impacts on mental health services are listed here. So, of course, it led to a reduction in access to services. There were many serious outbreaks and associated lockdowns in long-term care settings. We've all read about that. In some of the worst affected areas, of course, conversion of psychiatric wards into COVID wards. And of course, let us not forget the enormous strain, psychological strain that's been placed upon mental health and social care workers, as well as frontline workers as well, more generally. So some of the ways of mitigating against that include the retention of essential mental health services where feasible, the switch to remote forms of support and care through digital platforms and telemedicine, increased focus, as was mentioned by the Undersecretary, on self-help, the bottom of the pyramid. I'll come to that in just a second. And of course, ensuring good psychological support to healthcare workers. So this is what here we are back at these, the pyramid is the top right, but there's also the guidelines for mental health and psychosocial support in more emergency settings. So that's also another framework which is very valid in the current context, particularly where the outbreaks have been very severe and consequences being very severe. So, of course, there is this self-awareness and self-care component, and there are tools that have been made available to enable people to help themselves where they wish to. But then moving through this kind of spectrum or steps of different care, including the community, school, and workforce support, basic or non-specialized mental health and psychosocial support, like psychological first aid, access to hotlines, and so on. And then finally, the specialized mental health care and support people with pre-existing conditions or newly presenting conditions. So this was already touched on, so I won't go into more. These are some of the resources that are available. Hopefully the slides can be made available afterwards. You can click on some of these links to see the resources that have been developed in the last few months by different UN agencies, including the Interagency Standing Committee of the UN, which produced a lot of the really very well accepted and received guidance reports there noted. So finally, let me just quickly finish with some questions about the policy into practice. Now, I'm not going to go through all this, don't worry. I'm going to give you, these are some examples of national level programs that have been scaled up and demonstrated impact, which I think is very important, you know, when you're thinking about you know, how to address some of the issues identified in the Green Paper. How can you move this agenda forward? And we can learn from a lot of experiences around the continent. I'm going to choose a couple, one on suicide prevention, one on access to psychological therapies. You can see the others in the presentation. An example here is from Austria for suicide prevention. And the purpose of this is to you can look at the program description, and of course it's covering many of the areas that you'd want or expect to find in a suicide prevention strategy. But the piece which is perhaps, you know, the important part of this is to understand about what made this program successful and compared to other programs which maybe have been less successful. And what impacts did it really have? And I think in the case of this one, there were some key success factors or takeaway points. One was the establishment of a coordination center at the Public Health Institute to enable and support the process of implementation. That's often a big barrier. Also, this kind of low-hanging fruit concept. So the goals and measures that were already taking place, for example, improving media reporting, or things which were easy to achieve, like having annual conferences, they were put in place quickly to show early sort of success. But one of the really important areas in this one was a startup package that was developed and shared with provinces. So a subnational, you know, focus on subnational adaptation and needs. The UK, or England in particular, has been pursuing this improving access to psychological therapies. It's probably the biggest in Europe as a scale up of access to psychological therapies for people with depression and anxiety. It goes back a few years. There was an injection of government money and consequent training of a new cadre of therapists in CBT and other therapeutic approaches. So it's achieved a lot. I mean, it's reached like more than 1 million people a year. The recovery rates are pretty good. And we have there's a lot of new capacity, which was not there before. So again, what are the success factors there? What enabled this to take hold? And some of the key things here is around advocacy, including, let's call it economic advocacy, making the case, the investment case, linking it to the National Mental Health Strategic implementation efforts, as well as ongoing early evaluation of what it was achieving or not achieving, and therefore enabling adaptation of that. Some common barriers more generally are listed here. It include fragmentation of responsibility for delivery across stakeholders, fragmentation of funding, limited incentives, and the lack of often local champions to argue for mental health strategies. So these are some commonly occurring issues that you can keep also in your mind when thinking about developing services and the mental health system more generally. So with that, I'll just finish and say that I think a well-coordinated multi-sectoral strategy based on good evidence, anchored in human rights, integrated with other priority programs, provides a strong foundation for enhanced mental health promotion and protection. A couple of other things, innovation. So with this last few months, there's been actually a huge upsurge in innovation, use of new technology. And this is actually an example of how we can build back better in the area of mental health. And let's not forget the value of information, because not only is that in the sense of building up awareness and mental health literacy, but also monitoring what we are doing and tracking progress towards the mental health system goals that you've set for yourselves. So with that, thank you very much for your attention, and I pass it back. I'll stop sharing my screen and pass back to the chair.